we're going to talk about Chapter 4, which goes into treatment settings. This will be a fairly quick PowerPoint. This week, you guys had the ability to see some different treatment settings at your clinical sites. This just gives a background of how mental health has been addressed in this country, and starting way back during the Civil War. That's when we first started to see what we called like insane asylums or mental health institutes. Obviously, that would not be a proper word now. The first medications came about in the 50s. However, in the 60s, there was still no funding, so it took a while. In 1999, there was a huge push around the country to deinstitutionalize mentally ill patients. As a result, though, we did see homeless populations increase greatly. There's a lot of, I don't want to get too in detail, but there's a lot of information about if that was the right thing to do. So anyways, we saw a huge drop of psychiatric hospitals. And so now we have sort of this mix of outpatient and inpatient. While institutionalizing patients wasn't necessarily the right thing, we didn't always have then kind of a backup plan. So this has been sort of an ongoing problem in our country. How do we treat people who are mentally ill? As you guys saw, there's multiple different ways. Often people's first contact is with a primary care provider, and then often a primary care provider will go ahead and try to get patient into more of a specialty provider like a psychiatrist or a counselor. Often it can be months wait to get into a psychiatrist. Again, while this is why mental health nurse practitioners are such a kind of big job right now, and really very much needed in our country, because the wait to get into psychiatric care can be very hard. Access to care for mental health, for the mental illness population, is huge. It is very hard to find providers that are covered by insurance and etc. Patient-centered health or medical homes. This has to do with trying to have all the different types of care that's available, and having the patient be the center of that, and have it sort of be like a home health type agency, but it looks at all the different types of care modalities that are out there. Community clinics, we're aware of those, all different kinds. Psychiatric home care would be someone who's coming into the home, a little bit different than patient-centered in that psychiatric home care may be coming just to administer medications. And then ACT is a much more intense community treatment for patients who are incredibly severe. And these are people who are going to go out into the community with different types of like a mobile type of, we'll see this sometimes with people going through drug detox and things like that, where it's a 24-hour high acuity community treatment program where they'll send a team out to help with someone who's maybe psychotic or going through withdrawal and issues like that. So I just kind of want you to have an overall general idea of the different types of psychiatric care that's available. IOP, intensive outpatient programs. IOP is something that you'll hear a lot. For those who are at Norwegian, IOP is that outpatient program where they come for 3 or 4 hours a day for different groups. And then partial hospitalization is another term you'll hear often. So really the takeaways from these slides is I want you to understand we have inpatient, we have intensive outpatient programs called IOPs, and then we have partial hospitalization. And sometimes what will happen is this will be on an inpatient unit, but they don't spend the night. So similar to an IOP, sometimes IOP and partial hospitalization are used interchangeably, but those are the levels. When we talk about mental health care, we talk about levels of care. And it's very important that people are in the appropriate level. So someone who is suicidal, the correct level of care is going to be inpatient, right? It's not going to be a support group for depression. They are now need to be referred to a higher level of care. So we have, from online groups that people can be part of to face-to-face types of support groups to peer support groups versus a support group led by some type of clinician to outpatient programs, to intensive outpatient programs, partial hospitalization, all the way to inpatient care. So it's very important when you're treating someone that they're referred to the appropriate level of care, and that practitioners are able to identify what is the best level of care for a patient. So again, we have for emergency care, you have this hospital-based consultant model. So that's when someone comes into the ER and then we get a psychiatrist to come down. You have a mobile crisis team model, and Norwegian American Hospital right now has a mobile crisis team that actually does what they call a soft handoff. So they actually send they got $1 million grant to, they're looking at the opioid crisis, and they will actually send a mobile team out to help someone who's been referred and take them to the appropriate level of care, which is really a cool thing that's happening right now at Norwegian. And then comprehensive emergency service model is going to sort of incorporate all the above. This would be more like if someone was taken to a psychiatric hospital. So this question, I just kind of highlighted the answer. Which most accurately describes a patient-centered medical home? And this is when all levels of mental and physical care are addressed by a team that coordinates with the broader health system. So this is when it's in someone's home, and you may have a doctor as well as a psychiatrist, and they're all coordinating together. Community mental health systems are more emergency services or home-based services or outpatient services across the lifespan that are provided by an actual community. So, all communities need to have some sort of mental health plan, and what are their services. If a patient is just receiving psychiatric services in the home, that's psychiatric home care. And then this ACT is this team that works intensively with patients, and this is like that opioid crisis mobile team that can go out 24/7. So you have someone in the ER who is in opioid withdrawals, and your hospital doesn't facilitate that. So an ACT team can come and then transport that patient to the appropriate facility that they need to be. I want you guys to understand the difference between primary, secondary, and tertiary prevention. Primary prevention examples are things that we do to prevent the onset of illness. So we all know some of us may be more predisposed than others for various mental illnesses based on genetics, based on situations, all different types of things. And so primary prevention, an example would be teaching stress coping skills to students. So you're teaching it to all students. You're not identifying a subset of students. You're just broadly teaching stress coping skills to students with the hope that those who may be at risk for depression, that this will help to prevent that. Then you have the next tier, which would be secondary prevention. And this aims at reducing the severity after an illness has already presented itself. So for example, you also at the school hold a support group for teens who are diagnosed with anxiety. So now this support group is solely for teens who have a diagnosis of anxiety. And so this support group is going to be focused more on how they cope with their anxiety versus coping skills just across the board, not based on any sort of, based on primary prevention where it's not based on any sort of diagnoses. Then tertiary prevention is really going to be the highest level, and it's like an inpatient setting, maybe someone who's now become suicidal. Now we're into a tertiary prevention where we're trying to stop any sort of major complication, as well as help to get these people back to functioning day-to-day life. So that's the difference between primary, secondary, tertiary. I want you guys to understand that, to know, because you'll see that on tests moving forward. The nurse does a lot in outpatient settings. There's a lot of problem solving that happens. As we're all learning, there are multiple variables that contribute to a patient's mental health. And you can see how when they're mentally ill, how hard it can be to try to address. Some of them are homeless. Some of them, while you have teens, they may not have a healthy family situation. So there's all different types of skills and problem solving that go in an outpatient setting. And you have to be flexible because you're dealing with mentally ill patients. It's very important to know what your community resources are. You're often autonomous and doing a lot of this legwork yourself. And you're really trying to get these patients into recovery. Treatment recovery, it's a little bit tricky. People go back and forth if you can ever fully be recovered, but it sort of goes to, what's your definition of recovery? Is recovery that you're just a functioning member of society? Then I think we can get a lot of these mentally ill patients recovered. So that's the role of the nurse in outpatients. Inpatient settings is more short-term care now. We no longer see the long-term type of care we used to see in institutions when patients were institutionalized, which is a good thing because we're really trying to get patients to be functioning in society. So you have crisis stabilization and observation units that might be in, just a general hospital. You have private hospitals that are private psychiatric hospitals, often don't take insurance. When you think of, they're all over the country, but they can be very, very pricey. And unfortunately, if people don't have the means, they often end up in a state type of psychiatric facility, which isn't necessarily going to be the same type of milieu you're going to see in a private hospital. Most often, people are directly admitted to an acute inpatient care facility, either through the emergency department or a direct admit through a primary care physician or a psychiatrist. So someone goes to the doctor, they tell the doctor they're suicidal, and the doctor says, well, we're going to go ahead and directly admit you to an inpatient care facility. Or you go through an emergency department, you call a crisis hotline, and they go ahead and facilitate you going to an acute inpatient care. So acute inpatient care is that short-term, in-hospital, 24-hour care to get someone through a crisis situation. It can be voluntary or it's often involuntary. And so while you guys are in clinical, I want you to really look at the charts and see, was this a voluntary admission or has the patient been admitted against their will because other people thought they were a danger to themselves or others? And there's lots of legalities behind that, and we'll actually talk about that in 2 chapters. You can't just decide you want to, admit someone. There's all sorts of things. There's legal orders. They have to get a judge to agree to it. And I don't know if you guys remember, there's been Britney Spears was held on an involuntary hold at times. And so there's lots of legalities behind that because you want to, people's rights need to be respected. Here we go. So you do retain your rights as a citizen always. So they have to provide during times of voting. They have to provide an opportunity for these patients to be able to vote. And at all times, you have to balance the safety, what are their rights as a citizen. And so that's why we see all of these laws and policies regarding restraints. And restraints can be physical or they can be medical. So a medical restraint could be a drug. And so a drug like Haldol that's going to cause a patient to be incredibly subdued, out of it, calm down, is actually also considered a restraint. So we don't just look at physical restraints, we look at medicines that can be used as a restraint, and those have to follow very specific policies. You have to have tried numerous steps and prove and show and chart that those numerous steps have been attempted before you go to either of those kinds of restraints on a patient. It's really important everyone works together. I think you guys have seen that. Patients hopefully will follow a clinical pathway, and that's when we look at standardization of treatments. So, most patients are required to attend group. Most patients are required to have one-on-one counseling, and there's sort of these standards which we see help to improve patients' outcomes in inpatient settings. The therapeutic milieu, it's my favorite word in psych, mental health, nursing. We're going to talk a lot about this in class on Monday, but it has to do with your surroundings and your physical environment. And as you guys saw during your tours, there's a lot of thoughts that go into how you preserve a milieu, how you create a milieu, and how you maintain safety at the same time. When you're a nurse on the psychiatric unit, I really want you guys to pay attention. A lot of what the nurse is going to do has to do with medication and charting, because so much of psychiatric patients' care has to be documented to ensure that rights are being followed. And so often the nurse ends up kind of dealing with that and really making sure that the right policies are followed for seclusion, for restraints. She's sort of the gatekeeper for all the different team members in that collaborative team that's dealing with the patient. So there's different specialty settings. As we saw at Ingalls, they actually have a pediatric unit. I know there's a geropsych unit at Norwegian. I can't remember if there's one at Ingalls. VAs often will have their own psychiatric floors. Forensic psychiatric care is going to be more for someone who's possibly been accused of a crime or in a jail setting. We have ones that deal specifically with alcohol and drug use, as well as people who might, seek out a private healthcare facility to help with different types of addictive behaviors. So self-help type options. So there you go. I am going to go ahead and see. I'm sorry, I never know how I'm supposed to turn this off. So give me a second. I'm trying to figure it out. Oh gosh, I'm so sorry. There we go. Where's my little, here we go. File, escape. I think it's done.